Good morning and good evening. My name is Samara Andrade, and I'm the Senior Director for Clinical Training and Prevention at SightLife. We're thrilled that you've joined this webinar today to learn more about simple limbal epithelial techniques. Before introducing our incredible faculty that's here to share with you today, I wanted to take a little bit of time to let you know about SightLife, what we do, and how we work to achieve our mission to eliminate corneal blindness by 2040. Next slide. So to start, I really want to thank Orbis for our long-standing partnership to offer educational events for cornea care providers in low and middle income countries. On the international side of SightLife, we focus on 5 main program areas. The first is advocacy and policy, which works to ensure that barriers to successful health systems are removed by working with key opinion leaders and advocating to governments and working with them to build policies that work to address care and to increase the number of donated corneas and ensure that the health system overall is working for their communities. The second area that we're dedicated to working on is prevention and awareness, which works to prevent basic eye injuries like abrasions from progressing into corneal blindness by working with community health workers and eye hospitals in rural communities. The third area that we work on is clinical training, of which today's program is part of. Our focus in this is to ensure that there are qualified eye healthcare providers who can treat patients who need sight-saving surgery and to better manage corneal disease. The fourth area that we work is eye banking. We support the eye banking ecosystem to ensure that eye banks are implementing best practices and functioning at high efficiency rates to provide tissue for transplantation. The last area we work on is access and innovation, bringing innovative solutions to improve access to high quality, affordable care, empowering local healthcare providers to treat their communities more quickly and more efficiently. Through these 5 programs, we ensure that the health system is supported to be self-sufficient and meet the needs of the countries that we support work in. Next slide. So most of you here today are clinical care providers, and you probably have a particular interest in learning more about what we do on clinical training. So since our inception in 2013, we've directly trained more than 1,400 ophthalmologists directly in person in low and middle income countries and nearly 2,000 online. The way we provide in-person learning is through development of peer-reviewed curriculum. This curriculum is for different programs such as short-term corneal fellowships in PKP, where we take high-volume cataract surgeons and support them in transitioning into cornea. We also provide training in various surgical techniques, including DMEC, Dissection, SLET, as well as different educational programs for ophthalmic personnel like nurses and transplant coordinators. The faculty of SightLife are also serving as coaches and mentors for hundreds of corneal surgeons around the world. So today, we're very lucky to have Dr. Virender Sangwan here to give this webinar on simple limbal epithelial transplantation. It's absolutely my pleasure to welcome him. His passion for teaching comes through everything he does. Not only was he the first to describe this specific surgical technique in 2012, but he also worked closely with SightLife as a faculty for training courses and to develop a peer-reviewed curriculum on SLET, which is the first in the world. He also teaches many courses globally each year on SLET, as well as many other techniques. And you may have even recently seen him a couple of weeks ago right here on CyberSight. His generosity of time and commitment to education and training ophthalmologists is inspiring. So without further ado, I'd like to hand over to Dr. Virender.
Good evening and good morning to everyone. Thank you, Samara, for the kind introduction. And I would like to thank CyberSight and SightLife for providing this opportunity to share the ideas about simple limbal epithelial transplantation. And I will talk about simple limbal epithelial transplantation for the beginner and give you insight how we developed it. I have no financial disclosures to make in the context of this presentation. For understanding the SLET, let me make a brief comment about the normal ocular surface. Here in this short video, what you are seeing is the front part of the eye, and it's called the ocular surface. There are 3 critical elements which are essential for normal ocular surface. These are preocular tear film with all its components, surface epithelia, which are shown in this cartoon here, which essentially talks about the limbal epithelium going on to the cornea and then exfoliating the classical XYZ hypothesis. And then there is has to be an adequate amount of ocular surface sensitivity. Once you have all these three components, which is important for you to check before you do any surgery. Obviously, in patients with stem cell deficiency, some or other epithelium is abnormal. The elements of ocular surface defense include the stable preocular tear film, which consists of compositional factors and hydrodynamic factors. And all of you are familiar with these components, how they help in stabilizing the normal ocular surface. This at the brain level or the midbrain level is controlled by these two reflex arcs, which is the lid blinking and tear clearance. And both these motor nerves control the tear clearance. A stable tear film is essential for the healthy ocular surface. A healthy ocular surface is essential for the tear film. So they are interdependent and they are helpful to each other. When you have a injury or an insult or an autoimmune problem or a developmental problem, we get a condition called limbal stem cell deficiency. This consists of ingrowth of conjunctiva onto the corneal surface, in chronic inflammation, recurrent epithelial breakdown. And this happens because the limbal epithelial barrier function is gone and they are no longer able to resurface. And that's why the conjunctiva come onto the corneal surface. Obviously, you lose vision. There is a pain, redness, and eye may look very unsightly. The clinical spectrum of this condition can be total stem cell deficiency, partial. There can be classification based on congenital causes, idiopathic or secondary to trauma, or primary immune-mediated disease like Stevens-Johnson or ocular cicatricial pemphigoid. In this video, you are seeing some of the pre-op videos of my patient. Here at the bottom, I would like to draw your attention. This is a patient with VKC, and you see the dysfunction. This is not still a total deficiency because the cornea is healthy here. And this is also a destruction due to Moran's ulcer. This is total stem cell deficiency due to chemical burn. So it's very important to make a distinction between dysfunction and destruction. In both of these cases, you may not need a limbal transplantation, but here in this patient, you would need a limbal transplantation. Before we go further, let us just understand the terminology related to the limbal transplantation. And it is based on the source of the tissue, which can be allogenic when the tissue is taken from another human being, which can be a donor live related or a cadaveric. If it is autologous, meaning from the same patient's other eye or the same eye. So this is an autologous procedure. Classification can also be based on the surgical technique. This is like direct limbal transplantation, where there's a risk of donor site limbal decompensation because the amount of tissue we harvest is much higher. If we grow cells in the lab, it's called ex vivo cultivation. And this procedure does not have any risk for decompensation or deficiency at the donor site. And the more newer technique is simple epithelial limbal transplantation, which we will talk about today. So the rationale or the scientific basis of doing a limbal stem cell transplantation or limbal transplantation for LSCD or limbal stem cell deficiency is following. That you take a small amount of the donor limbus and transplant on to the affected cornea after cleaning up the pannus, and then these cells grow and resurface the corneal epithelium. In direct or what we call conjunctival limbal autografting, the amount of tissue, as you see here, it needs 6 to 8 clock hours, and that is why there is a chance for deficiency of the donor site. In cultivation, when you have a lab-based cultivation, the amount of tissue is about 1 clock hours and there is no chance of deficiency. And now SLET, what we are talking about, it's the best part of both CLAW and Clet. And the side effect or the downsides or the negatives of both the techniques have been eliminated with this SLET. The treatment of limbal stem cell deficiency essentially is surgical, and you will come, or you will be hearing again and again, CLAW, Clet, and SLET, conjunctival limbal autograft, cultivated limbal epithelial transplantation, and simple limbal epithelial transplantation. Live or cadaveric depends on the limbal tissue source, and it's usually an allograft, and therefore systemic immunosuppression is required. I'm not going to talk about the allografting today. We are talking about autologous simple limbal epithelial transplantation. I'm not going to talk about the conjunctival limbal autograft or cultivated limbal epithelial transplantation. However, I'll give a brief introduction about Clet. The first question, for normal functioning of the ocular surface, which statement is not correct? Surface sensitivity, preocular tear film, surface epithelium, the elements which are critical for normal functioning, and keratin expression by the epithelium. Practically 80% of you got the answer correct. That is, keratin expression by epithelium is incorrect answer. Now, let me share a story of a girl who I treated in 2001. She had a lime burn in one of her eye and came with a total stem cell deficiency, underwent a cultivated limbal epithelial transplantation in one eye, that is the left eye, followed by penetrating keratoplasty. And she underwent squint surgery, she underwent ptosis surgery, many, and now she's a grown-up woman. She is from Delhi, so I follow her up here, and almost 20 years now, and her eyes are still doing very well. She maintains 20/25 vision. Last year I had to repeat her corneal graft, but other than that, she's doing absolutely fine. So what is this cultivated limbal epithelial transplantation technique I'm talking about? This is a technique of growing stem cells in the lab, which we developed when I was in LVP. We started in 1999, 2000, and first cultivated limbal epithelial transplant I did in 2001. In this technique, you have submerged explant culture on de-epithelialized amniotic membrane, which you saw just here. And these are the plan for growing the cells. These red are the explants, which you can see here under microscope. And this is the green fluorescence. In this technique, there is nothing of animal origin. We use autologous serum, and we use to obtain a single monolayer. And our protocol has been published in Nature Protocols and being followed all over. Using this technique, we have published extensively and in peer-reviewed literature, and shown that the outcome of this technique are excellent and have been doing very well. Except that this technique has not worked very well in pediatric limbal stem cell deficiency. Why it has not worked? Really did not understand well. But in this paper in JAMA Ophthalmology in 2013, we showed that the success rate of Clet in pediatric LSCD is only 40%. And then a large percentage of them develop what we call amblyopia or the lazy eye. So we started feeling that there are problems with the Clet. Cost is one of the major consideration, and we'll talk towards the end of that talk what I'm talking about, how and why this is expensive. We need culture media, non-human products, genogenetic material. Then you need a laboratory which needs very high maintenance cost. You need for Clet 2 surgeries. First, for taking the biopsy, then you grow the cells for 2 weeks. Then after 2 weeks, you go back, and then transplant is done. And that is one patient. Now this patient, a 9-year-old boy, presented to our clinic with his father, and father said, can you remove this eye, because the boy refuses to go to school because the eye looks very bad, and he is being bullied by his friends. So what we did was, for us, by that time we had started developing the simple limbal epithelial transplantation. So in this boy, we did this technique. And as you see on the left panel, pre-op, and after about 6 weeks post-operatively, the cornea has cleared. There is a residual symbliphron superiorly, which was treated with the top-up SLET about 6 months later, You can see there's 20/40 vision. And this is the histology of the excised pannus, which looks very intense inflammation and granuloma formation. This is how we do this technique. This is a very brief introduction, taking the biopsy. And I'll be showing you next lot of videos about surgical steps. And I'll take you through each step. So you take the biopsy, deposit the cones back if you don't need for, as a conjunctival autograft. Then you clean up. This was very mild superficial limbal stem cell deficiency. After cleaning up, you do a little bit of cautery and put fibrin glue, bring the amniotic membrane, spread it all out nicely. And the biopsy which was taken, you keep in a BSS solution. Then you cut either with a 15 number blade. Later you will see I started using scissors. So these are, anything is fine, whichever works. And this is one of my very earlier videos when I was developing, that I did the fibrin glue first and then put the explants, which is quite messy. But later on I revised and I would put the explant first and then put the fibrin glue. You will see in subsequent videos. And this, in the bottom, you see the different time point, and about 6 months later, the eye becomes almost normal. So what is a good case for for doing SLET for a beginner? In my view, a uncomplicated chemical burn induced unilateral limbal stem cell deficiency, total or partial, without much simplifron, which is typified here on the top right corner. Any adult or a children with Lyme injury is preferable because the pannus comes off easily. You can find a plane as compared to the acid injuries. No underlying systemic autoimmune condition. Other eye should be normal, and you should be able to see a good, what do you call the palisades of limbal palisades. Examine the other eye. And these are other pictures I showed you earlier of dysfunction and destruction. These don't need surgery, therefore do not operate them. Which are the cases that you should avoid in the beginning? Bilateral cases, unless you have done even in the wet eyes, because these need allo-SLET and need systemic immunosuppression. So I wouldn't do those cases in the first 10 or 15 unless you are very familiar. Any patient with severe dry eyes like SJS, OCP, Sjogren syndrome, GVSD, unknown etiology of LSCD, especially in the Indian and African subcontinent, you have patients who have measles or viral fevers, and they develop total bone dry eye. Don't touch those eyes for doing these surgery, it won't work. Poor surface with decreased ocular or corneal sensitivity, post-radiation, post-OSSN excision, local or systemic immune-mediated diseases, which cause limbal stem cell deficiency. So in the beginning, avoid those cases. Select simple, straightforward, wet eyes. What do you need to do a SLET? You should be familiar with the surface surgeries, meaning you should have been doing good pterygium surgery, OSSN or dermoid removal. You should be familiar with doing corneal surgeries. You should be able to assess the visual potential in the eye to be operated. Sometimes you may consider doing surgery even in a PL negative eye for cosmetic enhancement, but those should not be your first few cases. You should be able to do a proper workup and informed consent. You should be able to understand post-operative requirement, what the course of action would be, and BCL should be put and kept for 2 weeks at least. And when in doubt, do a tarsophy at the time of surgery. I'm showing these 2 videos. The video which says bone dry, which is essentially different stages or different types of Steven Johnson, please do not do any kind of limbal transplantation in these eyes. They don't work. There can be a modified protocol, but I can talk that later or in question answer or some other form. The video on the wet surface, these are chemical burns. They are good enough, but at different stages of disease. So select simple, effective, or simple, uncomplicated cases in the beginning. What are the indications of SLET? unilateral bilateral limbal stem cell deficiency, which is total or partial with decrease in vision or symptomatic patients. LSCD is surgical disease and medical treatment is not indicated, not required. Cosmetic enhancement if visual prognosis is poor, but that is only after you have done 5 or 10 cases and you're familiar. SLET is now being done as a preventive or a primary surgery along with excision of OSSN or recurrent pterygium to prevent limbal stem cell deficiency. The time for the second question. What is the best treatment for unilateral total limbal stem cell deficiency caused by chemical burn? Only about 4-5% people did not get it correct, and you should be able to get it by the end of this. Simple limbal epithelial transplantation is the correct answer. Now let's talk about surgical technique, post-operative management little in detail. This video is the original video of Kent Kenyon and Sefer Singh, who described the limbal stem cell transplantation for limbal stem cell deficiency way back in 1988, 1989, when both of them were in Mass Eye and Ear Infirmary. As you will notice, they're starting to harvest the limbus from the corneal side. And if you see my video, how I start exactly opposite. I start from the conjunctival side. And you will see this the way of harvesting biopsy again and again. But the downside of harvesting from the corneal side is that you don't know what the plane, how much deep you have to go. If you start from the conjunctival side, you know what the conjunctiva is, what the Tenon's capsule is, and what the sclera is. So you want to go bare sclera, then dissect a blunt and sharp dissection towards limbus, and then you keep harvesting until you reach limbus, and we will talk about this in further videos. Before that, I'll show you how we do the Panda's dissection. All of you will agree that it's a total stem cell deficiency, and barely you can make out if there is a cornea or no cornea. As we start this video, you start dissecting the Panda's from periphery of what you think of where the cornea might be. And it's always good idea to put your scissors closed prongs of the scissor and go underneath, undermine, and then remove the adhesions and cut it, make a space, and then bit by bit, use 15 number blade, sharp instrument, as much avoid as possible. And certainly I don't recommend using super sharp blades or diamond knives or crescent knives. They will create multiple planes and you will go in unwanted areas. So my best instrument for this dissection is 15 number blade on BP handle. When you reach this, now you are convinced that this is a cornea, looks nice, and you do a cautery a little bit and then put the amniotic membrane, and we'll see in the further videos like here. So first you harvest biopsy, watch it carefully how I am doing it. 15 number blade, Tenon's cutting, and then my assistant start pouring continuously the water, because at this stage you should not do cautery, and you should learn to harvest or operate under water. Here the variation I'm showing is I did a snip biopsy from other area and did at the donor site, so that preventing the limbal stem cell deficiency at that site. Now this is the affected eye. So I did the limbal biopsy first, put it in the BSS on the surgical trolley, and then I started dissecting. And make sure that you tell your nurse that do not throw that limbal biopsy, don't send it to pathology, don't put in the formalin, that you need it. And look at I'm doing dissections in different ways, trying to find the plane of insertion of the Panda's onto the cornea. And how do you know that? Once you start from the periphery, away from the limbus, the adhesions are most severe at the limbus. Once you dissect them, come towards cornea, you will be able to see the plane. And you should try to find the plane and do not remove the corneal fibers at all. Once you clean up, hemostasis is achieved, fibrin glue, both component, the thick one first, that is thrombin, and then fibrinogen, then you bring the amniotic membrane, or you can put the amniotic membrane, lift upper one half, put the glue, iron it out. Some other people do that you drape the membrane first, and then under the membrane, you go and inject the glue. Then I'm now using the scissors and forceps. These are both micro scissors designed by Josa Surgicals for me, but they are available from him. You can also use this retinal, intraocular retinal forceps and scissors, maybe 18, 20 gauge or 23 gauge, which may be a bit fine, but they are very, very good. Then use the fibrin glue, both the component, wait for a minute, and then put the bandage contact lens. You can make a choice whether you want to do a tarsorrhaphy or not. If you do, can do for 2 weeks temporary tarsorrhaphy to prevent the loss of contact lens. Here I have gone a little too deep in the cornea. If you see here, this is corneal fibers. So you have to be careful that you don't perforate. The rest of the procedure is the same. You put the fibrin glue, excess membrane, and a BCL. Here, if you see, there is limbal stem. Limbus is superiorly not very healthy. This area is not very healthy, so I'm taking slightly temporal area. You can take the limbal biopsy from most preferred area is the superior limbus, inferior limbus, then temporal or nasal. Harvesting inferior any other site other than superior is a little more difficult. You need to have you need to be ambidextrous and it should be able to manage. This is the affected eye, and you start dissecting pannas 2 to 3 millimeter away from the limbus because you have a clear definition of the conch, subtenon, and the conch in this area. And then you start going towards into the clear cornea. Remember not to remove the corneal fibers, even if there is scar. Sometimes you may need to do pachymetry if you are not sure thickness is there good enough or not. I would like at least 200 to 250 micron residual bed. What you are seeing, this is a PLGA membrane, which I'm developing as a substitute for the human amniotic membrane. This is still under development. And one day I hope that we can do SLET without amniotic membrane, without fibrin glue, because in most of the world, these two things are not that easily available. And I'm actively working and trying to find a solution to these problems. And this is an example of a temporary tarsorrhaphy that I did in this patient for 2 weeks until the BCL is in place. Now, this is a video which is has its own audio, and you should be able to enjoy all the steps which we have talked about so far.
Healthy corneas lined by non-keratinized stratified squamous epithelium demarcated by the limbus from the conjunctival epithelial phenotype. The limbus contains radially oriented fibrovascular ridges called the palisades of Vogt. Immunohistopathological studies involving the limbus and ultrastructural imaging involving the palisades of Vogt using in vivo confocal microscopy have revealed that these limbal stem cells are located in a protected microenvironment known as the limbal niche. It comprises of a limbal epithelial crypt harboring the stem cells, which proliferate and migrate centripetally to form the corneal epithelial cells. Chemical injuries to the eye caused by acids or alkalis destroy the limbal stem cells. Severe surface insults eventually lead to propagation of conjunctival epithelial cells, limbal stem cell deficiency, either partial or total, characterized by vascularization, conjunctivalization, corneal scarring, symblepharon, in extreme cases inability to open the eye. Pannus is a well-documented clinical feature. It has to be dissected and replaced with a scaffold of healthy live limbal stem cells, which in unilateral cases can be harvested from contralateral healthy limbus. Simple limbal epithelial transplantation, commonly called SLET, is a technique first described by Dr. Sangwan et al. For unilateral cases. First, a limbal biopsy is harvested from the healthy eye and preserved, followed by Pannus dissection in the affected eye. Amniotic membrane is applied and small bits of limbal biopsy are secured over it with fibrin glue. We shall now demonstrate the technique of limbal biopsy. The normal eye is draped. The conjunctiva is cut and the tenons is dissected. The incision is extended with Vanna's scissors to about 2 to 3 o'clock hours. The dissection now proceeds with a 15-number blade and the correct plane is reached when the cut limbal blood vessels start to bleed. We proceed further into the cornea, avoiding buttonholing of the tissue. The limbal tissue is harvested with a pair of scissors at the level of the limbus, leaving a strip of tissue still attached to the cornea. The cut conjunctiva is now reposited back with fibrin glue. The limbal biopsy is placed in normal saline to prevent drying of the tissue. The different techniques of Pannus dissection, one of the most crucial steps, will be presented here. The affected eye is draped. The Pannus is carefully dissected, starting at the limbus with and then onto the cornea. A 360-degree peritomy is done. The dissected area on the sclera is cauterized. Thrombin powder may be used to achieve hemostasis. Pannus dissection is done with a 15-number blade until an appropriate plane is found. Dissection is extended with an iris repositor. Every effort must be made to find this plane. Meticulous dissection needs to be done as it has a bearing in the final visual outcome. Ability to view the iris can be a useful marker. In certain cases, the appropriate plane may be found by simply peeling the Pannus from the cornea. In severe cases, the skin too may be adherent, making it difficult to position the speculum. In such cases, skin tags need to be cut and symblepharon release done in all the quadrants. The speculum is now easily applied. Further dissection is continued. The bed is dried and the amniotic membrane is placed on the eye and attached to the ocular surface with fibrin glue. The excess tissue is neatly trimmed away. The limbal biopsy is then divided into multiple tiny bits against a hard surface like Teflon block with a 15-number blade and placed over the amniotic membrane. It can also be done with micro scissors or more often with Vanna's scissors. The limbal tissue bits are arranged equidistantly in a concentric fashion, avoiding the visual axis. Fibrin glue is applied on each of the bits and allowed to polymerize over the tissue. A bandage contact lens is then placed over the eye. The speculum is gently removed and the eye is patched. Post-operatively, this technique stabilizes the ocular surface with rapid epithelialization and clearing in the transplanted eye. The donor site remains healthy. It also heals rapidly in just a few weeks. When done meticulously, this procedure provides gratifying anatomical and visual outcomes. Recent published studies across the globe have shown that results similar to long-term outcomes from our group have been replicated by several other groups. This novel technique is cost-effective and can be performed as a single-stage procedure at any ophthalmic institution without needing a sophisticated laboratory setup. In conclusion, Simple Limbal Epithelial Transplant is a novel single-stage technique in the management of unilateral limbal stem cell deficiency with gratifying surgical outcomes.
Well, now what are the intraoperative questions that will come to your mind? Whether you should use a local or a topical or general anesthesia. For pediatric patients or patients who are not cooperative, use general anesthesia. And rest of everybody, I would do under peribulbar. I warn you that don't use topical anesthesia, even though surgery can be done, but because harvesting with the limbal biopsy is a very delicate procedure and you don't want to tear and lose the stem cells. When you're taking the harvesting the limbal biopsy, some people feel, should I do biopsy first or should I remove the pannus first? What will happen if I remove the pannus and I perforate? My biopsy may go waste. So I have been subconsciously doing the limbal biopsy first and then pannus dissection, and there's no problem. Some of my fellows taught me that they would like to remove the pannus and are sure that everything is okay, and then they harvest the limbal biopsy. And also it may give you an advantage that tissue is not outside the eye for a longer time. So whichever way you are comfortable, you can do. What happens if I have perforation while dissecting the pannus? That will depend on the size of perforation. Say if it is a very tiny perforation which gets sealed with the fibrin glue membrane, it's okay. If the eye is not soft, you can go ahead. If you detect the perforation while dissecting, you can go back and put the suture and still you can go. If it is a large perforation which you think cannot be sealed by usual means, then think of doing a graft. If you have harvested the limbal biopsy, I suggest you put the limbal biopsies instead of the entire cornea, you can put on the graft host junction after putting the amniotic membrane. While dissecting the pannus or biopsy, how deep you should be. I have shown you in the videos, it's very difficult to quantify, but the visual impression that you want to be is at the level of the depth of the conjunctiva and 10 inch, no more. In the cornea, when you come, it should be just where the limbus is inserting into the cornea, follow that plane. Another question, can we combine PKP or LKP with SLET? As a planned procedure, I don't recommend, mainly because first do the procedure like SLET, and once that is successful, then only do a PK or LKP. And now I'll show you further that following SLET, the need for PK or SLET, PK or LK is very, very low chance. You may not need in many of the cases. If you perforate and then you have to do, then it's okay. Which one to do first? If you have a patient with limbal stem cell deficiency in a patient with PK, should you do SLET first or PK first, or a combined? Again, depending on the situation, my preference would be to do the SLET first and see if the procedure has worked, and then only you do PK. Another rationale for not combining is surface procedure. As far as possible, don't combine with them intraocular procedures, because then you are opening the avenue for potential infection. If it had happened during the surgery, then it's a different situation. The postoperative management of a autologous simple limbal epithelial transplantation would consist of topical steroids, typically predacetate or equivalent, every hour for the first week, and then every 2 hours, then make it them 6 times a week, 6 times a day, and the donor eye continue 6 times and antibiotic 4 times. Taper weekly in the donor eye, antibiotic can be stopped after 2 weeks. And in the recipient eye, the antibiotic should be stopped once you remove the bandage contact lens and when the epithelium is healed. Usually, you don't need systemic medication for the SLET patients because it's autologous procedure. You don't need systemic antibiotic, except some patient may need some analgesic orally for a day or two. What you can expect post-operatively, or what you look for post-operatively. On day one, when you're removing the bandage, be very careful that sometimes the membrane and the exudate sticking on the eyelid margin, you can pull the BCL or the membrane along with it. So be very diligent, be careful. You should note the AMG with explant is present, BCL is present, eye is moving properly, there is no infection, and there is no discharge. Discharge is expected as much as what you do in an operated eye. You may expect some fluid or a hemorrhage under the membrane, very rarely. And you don't really need to do anything, no intervention required for such. If you find there is no AMG or explants or bandage contact lens, there is a chance that when you are removing your drape, you have pulled it inadvertently. What you should do in that situation, don't panic. What has to happen has already happened. So continue your treatment and observe the patient for a few days and keep the bandage contact lens. Very high chance that this patient will develop limbal stem cell deficiency, but to reoperate or not, I think you should wait for a few weeks. If the BCL is lost in the first few days, replace it up to 2 weeks or until the epithelium is healed. And epithelium healing is indicated by negative fluorescein staining. Now the time for question. All the statements are true for SLET except it is equally effective. It is equally effective both in adults and children with LSCD. It is a single stage surgery. Fetal calf serum drops are required post-operatively. Expensive stem cell laboratory is not required. The question was all the statements are true except which one? Fetal calf serum, the C is the answer because we don't need any of these fetal calf serum or anything. This is a patient who had a granuloma following chemical burn, and this is the post-op appearance and the donor eye. This is a patient pre-operative on the left side and post-SLET at 1 year. This is 2-year follow-up. This is 3-year follow-up. So you can see that as the time goes by, the cornea becomes clearer. And this is demonstrated in this particular patient. So you see this is PL positive in July 2011, total limbal stem cell deficiency, undergoes SLET. About a month later, you see a lot of scarring, you see the explants there. Then in about 6 months later, there is some clarity, further improvement. And at this stage, in March 2012, we offered him doing a DALC or PK, but the patient says, I rather wait. And he was wise enough. As you wait, the cornea becomes clearer. And eventually he develops 20/40 vision and cornea clears. Why this clears? Now we have an evidence that the mesenchymal cells, which are part of the limbal biopsy, are the ones which keep working and they clear the cornea over a period of time. Now we have enough scientific evidence, publications, and we in fact started doing mesenchymal stem cell therapy for corneal scars and prevention of corneal scars. Another unique application of SLET is in patients with OSSN. When you have a small, less than 3 clock hours tumor, you don't need anything because they usually don't develop stem cell deficiency. If you have more than 2 clock hours OSSN at the time of excision, you should do a SLET. Otherwise, you will definitely develop stem cell deficiency as seen here in this picture, case 2, bottom. Now, this is another example of doing a excision of large OSSN combining with primary SLET and excellent outcome. And this now has been published by Dr. Swati Kalki from LVP in AJO couple of years back. This is pediatric limbal stem cell deficiency, a case published by Vikas Mittal from Ambala. And you see this in 2010, a severe LSCD. This is on top is the face pictures and bottom is the eye picture. And you can see how the eye or the cornea clears over a period of time. This is a patient done by us, a 2-year-old boy with a toilet cleaner, underwent a SLET in the acute case. And I would recommend, if you have a child in the myopic age group, do a SLET in the acute phase. Don't hesitate. You will save the eye and you prevent the amblyopia. And this is the study that we had published of 125 eyes in journal Ophthalmology in 2016, wherein we showed with a well-defined criteria for success and failure, we showed that the success rate in adults and children are exactly same. And remember, I told in Clet, we are not able to achieve this. Number two, the visual acuity improved significantly in both the groups. And number three, the graph is there in the paper, but not here, that the technique, the learning curve is not very difficult. We compared the outcome of cases done by me and by a junior faculty and by our fellows. And surprisingly, all three groups did very well. This is the immunohistochemistry of excised corneas, of few corneas in the initial stage when we had to do a PK or a DALK, and it shows a phenotypic restoration of corneal phenotype after the SLET. And these are further replication of these kind of results by other groups. This is a multi-center trial wherein people from different countries got together and shown the outcome which we have shared in the paper in ophthalmology. And another interesting point is that this technique can be modified by different surgeons based on what they think for what indication. Like, someone described a customized SLET or mini SLET for pterygium, or a sandwich technique for LSCD. Now, if you look at this summary, it's our first paper was published in 2012. Till date, in the peer-reviewed literature, there are 450 patients who have received SLET, and these are from 8 countries. There are 30 publications of SLET as of 2 months back. And for last 5 years, there has been no single publication about Clet. We have done several workshops to teach surgeons from different countries. And these are the graphs showing the cases and the publication over a period of time. And this is the comparison of 3 techniques, CLAW, Clet, and SLET. And if you look at the success rate, anatomical and visual gains are very comparable, very, very much comparable in all techniques. So it is just the safety of which technique and which is affordable. When we compared the 3 different techniques on these 7 parameters, what turns out is SLET is better or equal in most of these parameters of safety and efficacy and affordability and repeatability. And this is the summary of Clet outcomes. You will notice that most of these work is done by a group in Italy and another group by us in India. Other players are very small number of publications or small number of eyes. This is a very important slide where you are seeing what I mean that is cost effectiveness. This is the recent data, which is yet to be published, where we are saying the cost of a SLET in India in LVP and Shroff is $700. Cost of Clet is $7,000. Similarly, in Europe and now in US also, a holocular-based technique or Clet-based technique called holocular, which costs about 85,000 euro. So obviously, such an expensive treatment cannot be afforded even if the government pays for it. Now, just a summary of differences. I'm sure there's a repetition, but it's worth it. The SLED is a single step procedure. Clet is 2-step. It's more expensive, not replicable because there are hardly any groups who have replicated this procedure. There's no risk of contamination in the SLET, no culture related, no secondary biopsy required. And the long-term and outcomes modifications, we have talked all of them. The question 4, for autologous SLET, what is not indicated in post-operative period? Remember, this is autologous SLET. topical antibiotics and steroids, bandage contact lens, systemic immunosuppressive free, oral analgesic as and when required. So the question is, what is not indicated? Lovely. Very good audience. You got it. Thank you very much. So now let us quickly review what is the mechanism of limbal regeneration post-SLET. This is, you have seen in that video, and this is a beautiful work published by Vikas Mittal of imaging his patient, few of his patient every other day, removing the contact lens, staining, and you can see that clearing or epithelialization is indicated by no staining. And in about 2 weeks, you get almost complete healing. And this you can compare when healing pattern is very similar to the pattern of cell growth in Clet. On the left-hand side panel, this is the cells growing in the lab from each explant, and correspondingly, you can see the similar pattern in SLET in vivo in human eyes. And in about day 10 to 14 days, roughly, you get monolayer, and then the stratification happens. Here, if you compare the healing pattern with the claw, which is from Dr. Kent Kenyon and Sefer Singh's paper of ophthalmology in 1989, you see the central cornea, which is the most critical part, heals the last. You are likely to get scarring, you are likely to get PED, while in the SLET, each explant is like a mini limbus. So there is a multi-directional epithelial growth, and all the cornea, all parts of the cornea equally heal fast, and there is no lag. How does SLET works? Each of these implants or explant have a growing cells all around. MSCs, which are part of the explants, are successful contributing to the success, and they're exosomes secreted by mesenchymal cells. The limbal explants in SLET, they stay longer on the surface, and they continue to serve as a kind of a mother cells clearing and sending the epithelial daughter cells. And these implants are like mini limbus with all its cellular and ECM elements, extracellular matrix elements. This is another amazing study we did, still not published, but high definition ASOCT of these patients serially. If you look at on day 1, day 5, day 8, you see the flattening of these explant or transplants or whatever you call implants. And as you progress on day 11, you can see the epithelialization and the amniotic membrane thinning and start disintegrating. And in about 6 weeks, you see a stratification. In 6 months, you may not be able to identify. There may be a rare patient who still have an explant there. Like in this patient, you can make out there is a white spot. And this is compared with a normal cornea. So in summary, the SLET is an effective procedure which restores corneal surface and improves vision. It is replicable because it has been reported, similar results are reported by other groups. It is repeatable, it is affordable, eliminates the need for stem cell lab or no regulatory requirements. It's reliable, it works very well in children and adults, and there are further applications like in OSSN, recurrent pterygium, persistent epithelial defect, acute chemical burns, and open platform technology. It is not owned or protected by a patent. Therefore, surgeons can innovate depending on the situation, depending on the indication, what they are encountering. Thank you very much for your kind attention. The first question, got a 67-year-old patient with conjunctivitis on the lower side of the cornea due to distichiasis and also clear neoscale. Should this patient be perfect for start? And also here in Indonesia, we only have a dry amniotic membrane. Can it work? Well, I think in this first case, I would suggest that you first try to rectify the distichiasis. And if it is due to SJS or if other problem, then this technique is not good. So understand why the stem cell deficiency. And dry amniotic membrane probably is okay if you have the glue. Anonymous attendee, thank you for the excellent lecture. Please, why is the absence of simple epithelial SLET? Well, the reason it's not a prerequisite, but it is easy for people who are learning. because once you have symblephrone, that means there is a more severe problem, and you need to be skilled enough, and maybe you need to do surgery in stages rather than combining. What you saw in my hand, I have been doing it for almost 25 years, and I'm quite okay, but many of complex cases I also do in a staged manner. Dr. Ashraf, so all cases are not recommended except after traumatic or chemical injury. By and large is correct only for the beginners. What I said, for beginners, start in chemical burns. Aniridia, GVHD, OCP, Steven Johnson, all these kind of cases that you should take once you are very comfortable and familiar. Can we use femtolaser to get the band of limbal tissue? Well, this is like, you can if you have this, but I have not tried, so I don't know. If you are able to, please let me know, because it might be a very good quantified way of getting this. What are the prognosis of this technique? Prognosis, as I've shown you, is excellent, about 78 to 82% success rate. And now we have 5-year follow-up as well. Please repeat the harvesting of donor tissue once more. Well, I can share this, some of the videos, and maybe CyberSight will have this lecture. So you can watch these videos, or you can reach me through CyberSight about any specific request. I'll be happy to share more videos or answer more questions. Alka Pandey, when do you do penis dissection? How does the cones come back? As I shown in the videos, Alka, you start the penis dissection from periphery, you remove, the cones comes back from all 360 degrees, which we have cut margin. From there, the cones comes back. And by then the limbus and the cornea has healed, so it prevents the cones coming over to the cornea. What about the orientation of donor pieces? Well, don't worry about orientation. Epithelial side up or down, I don't think it matters. Even though we have written in the paper that epithelial side should be up, really doesn't matter. Do you recommend SLED for large pterygium as a primary? Yes, I do recommend SLED for a pterygium. But for the conjunctival part, I'll still use a conjunctival autograft if there is a large pterygium or double-headed pterygium. What is the success rate of allo-SLED? Allo-SLED I have done fairly okay, and I would say success rate with good immunosuppression is excellent. Like Clet, allo-Clet, which we have published several years back in AJO, success rate at 5 years was 72–75%. After injury, how much time interval is needed to go for SLED surgery? I would wait until the epithelium heals or do the amniotic membrane transplant in the acute phase. If it's a pediatric eye, then you can do the SLED. Or you can also do cadaveric SLED, where you don't need immunosuppression for epithelialization, and you can do it along with the amniotic membrane. The implanted stem cell on top of amnion, yes. Because the amniotic membrane provides a scaffold on which the cells grow. You can put directly on the cornea. I have not done so, and I think the explants might move when you adjust the amniotic membrane. Since I have been growing the cells on the amniotic membrane for Clet, I felt that using replicated the same technique in the eye would be a good thing to do. That's why I have not attempted the explants on the cornea directly without amniotic membrane. How many pieces are needed for the cornea? 10 to 12 pieces on average. How long should the contact lens? About 10 to 12 or 14 days till the epithelium heals. Steroids, I would do the slow taper over 6 to 8 weeks. Success rate of SLET is about 80% in chemical burns. After gluing the amniotic membrane, you put the stem cells. Why these are keep moving? Explain more glue, or yes, you will put the fibrin glue over each of the explants. What is the success rate of SLET as primary? We talked about how long does it take complete whole procedure. In my hand, it takes about 30 to 40 minutes. Side of photograph tissue, that should be up. It really does not matter which side up. We prepare the amniotic membrane ourselves in our eye bank, and that we have been doing in the LVP eye bank as well. I have been doing allogenic SLED, Mohammed, yes. Farad, I have been doing allo-SLED for quite some time now. Can SLED be used for corneal scarring without LSC? No, I don't think that's a very good idea. Mesenchymal cells, yes, they can, but in the mature scar, they may not also work. In the acute stage, yes. Nupur, sir, in case of chemical injury with corneal melt, granuloma, total edge, should you be stepwise approach? Yes, I would be stepwise. Large dermoid, Mortaza, I would do SLED definitely in that area of the cornea and limbus side. How many times SLED can be take? Okay, I didn't understand the question, but I have done SLED 2 times, 3 times, and in case of SLED and Clet, I have done even 4 times. The amniotic membrane side, the epithelial side of the amniotic membrane is up, the stromal side is down towards the cornea. Please repeat the steps. Why the amniotic membrane is side up? Because the epithelial side is up because putting the explant, manipulating them is much easier, while the sticky side you want on the cornea so that it sticks nicely on the corneal surface. What is the time in residency for you, ask agent, to learn this technique? Andres, it depends on your program. Anyone who's familiar with the surface surgery can be taught this technique. Can SLED be done without AMG? Well, you can try. I have not done, but if you have the fibrin glue and then maybe try. I have not done, but I'm developing a synthetic or a bioengineered PLGA membrane with a company in UK. Is suturing of the graft and obstinate fibrin not available? Well, the amniotic membrane you can suture. It's very easy. I can show you or say there's a video if you want later on or through the CyberSite portal. But for if you don't have fibrin glue, maybe use the whole blood and use these blood drops as a part of the glue and allow them to clot and then put the amniotic membrane. That might work. I have not done myself. Mohammed Sayed, thank you very much. Is there any limit of interval after trauma doing SLED? Generally, if the other eye is okay, and if the patient is not pediatric, you should wait for at least 6 to 8 months until the surface is not inflamed and healed completely. Just I answered that, Kavita. Can we do SLED in old chemical? Yes, I have done SLED as old as 20, 30 years post-chemical burns. And my oldest patient of Clet was 40-year-old chemical burn in both eyes. In acute stage, what is the advantage of SLED with the AMG in comparison? Well, I'm not talking about in acute stage AMG. I prefer AMG alone, but there is a paper and an experience by Dr. Geeta Iyer from Sankar Nethralaya, wherein they used cadaveric SLED as a procedure for epithelial healing. Sometimes the amniotic membrane in the acute phase disintegrates very rapidly and you need to repeat very quickly. So for that reason, if there is no fibrin glue available, where do you recommend to use put suture? Well, for the Herbert, if you don't have the fibrin glue, I suggest you use the whole blood rather than suturing these explants. It will be very technically difficult. Any particular donor tissue orientation? Donor tissue orientation really does not matter, and I would not pay much attention. Mucous membrane grafting. Mucous membrane grafting is generally reserved for patients who have lid margin keratinization or symbliphron, which is not amenable with cones or you don't have enough cones. All cases use fibrin glue before AMT. Fibrin glue is essential for sticking the membrane on the ocular surface, but not absolute essential. You can use the sutures, 10 or monoflant sutures, and then for sticking the explant, the fibrin glue is required. because I don't know what other way you can stick the explants on the membrane. In large pterygium, does you take the donor from the same eye? Yes, if there is a, even if 2 to 3 clock hours limbus available, I will be happy to take. And we have a nice paper published about ipsilateral SLET as well as ipsilateral Clet. What can be used in place of amniotic membrane? At the moment, I really don't know because I don't have a synthetic membrane. If you don't have the membrane, maybe try cleaning the penis and use the explant directly onto the cornea and use fibrin glue. If you don't have fibrin glue, try whole blood, patient's own blood. Can we use the amniotic membrane rather than PCL? Yes, absolutely fine. That is what Guillermo Amascua from Basket Palmer did. He was scared that the explant will fall, so he used another membrane on top of the explant. That's perfectly fine, and it works very well. Does MMC application intrasurgery will give advantage? Really not necessary unless you have very severe Simplifron, Aziza. If you have Simplifron fibrosis, you can use MMC and wash it completely, and that should be fine. Have you experienced any complication when you remove the BCL? Not really, because BCL is generally free. There's no adhesion, there's no sticking, and there's no problem. If it is failed, Zarina Jarni asked, can we repeat SLET? Yes, you can, but take the biopsy from at least 2-3 clock hours away from the initial place of biopsy. Can we use industrial glue? Ahmed, no, not a good idea. Industrial glue or the what we use in construction industry is very toxic, and the stem cells will not tolerate that. How to get amniotic membrane? Purvi Dalal. It's very simple. Those of you who don't have the amniotic membrane, please contact me through CyberSite. I'll share my video of how to prepare the amniotic membrane in any situation. And in India, it is available commercially from different sources. Which is placed first, AM or limbal stem cell pieces? As I shown in the video, after cleaning the penis, first do the gentle cautery, achieve hemostasis, then amniotic membrane and fibrin glue, cut off the excess membrane, then the limbal pieces on top of the amniotic membrane, and then fibrin glue again and BCL. Maria is asking, when you put glue over the biopsy and BCL, don't get, no, they don't stuck. So that's why when you, after putting the explant and then the glue, wait for about a minute. And even if you don't wait, fibrin glue is wet, the contact lens will not stick because it is plastic and it's very smooth. You do not, the glue does not stick to the contact lens. What happens for transplanted amniotic over time? The amniotic membrane gets disintegrated by the enzymes in the tear film and the leukocytes present in the tear film. In rare cases, you may get integrated on the cornea, but not very often. And that was a paper published by Harminder Dua several years ago in ophthalmology that he found in some cases the amniotic membrane collagen in the cornea. If we don't have fibrin glue, can we put the donor stem cell first and then stitch the membrane? Yes, that may be a good idea. Yes, I think that might be a good idea actually. That if you don't have the fibrin glue, you can put the fibrin glue directly on the ocular surface, I mean the explants, then maybe use blood and then the amniotic membrane on top, and you can suture the amniotic membrane. Please try and let me know if it works. Sarthak Bafna, sir, any chance to do procedure without amniotic membrane? Just talked about, yes. Thank you, Madhusmita. Paolo Dantas, dear doctor, I'm a huge fan of your work. Thank you very much for kind words. How do you compare SLET with Clet in long-term ocular surface? Well, just shown you the only problem with Clet is the amount of tissue you take. Other than that, there is no problem. And if you're happy with the Clet and the results, then you really don't need to do SLET. Because the amount of tissue you are taking in SLET is considerably less. And in my videos, you may have realized that I'm still taking much more than what needed because these are old videos. Now I just take a very tiny amount. Do you have any specific plan for distribution limbal cell pieces? How about central 3 million? Yes. Very important, Murtaza, very important question. I did not touch upon. So let us understand. If the central 3 millimeter of the cornea is very clear, then you should not put the explants on the visual axis because the opacity and the presence of the explant can distort visual acuity. So I will avoid those and distribute only in the mid periphery and just about 2-3 millimeter inside the limbus and not the central cornea. If there is scarring or the cornea is not clear, then don't worry about it. Chavi, thank you so much. Thank you, Chavi. Would you recommend use of SLET for failed PKP? Yes, I would. Failed PKP, if there is a pannus. Failed PKP with normal limbus, I'll do a PKP again. And thank you, everyone.